Good morning, everyone. Welcome to Coffee and Cases. See, we still have a few people joining. Just a few reminders before we get started. Please don't put your personal details in the chat at all. A link will be shared for you to go and log your details. We're gonna be speaking today to Karika, who is an IPC sister who's working at Santon, and she's going to take us through some sort of superbug challenges for the EMS environment, but also maybe how it applies to the in-hospital spaces and how we can do better to not cause trouble. Just in the meantime, while we're waiting for the last few people to probably join in, just reminders that this is a really safe space. So if you have any questions, if you have any concerns, challenges, cases that you maybe want to bring up in relation to the presentation today, please feel free to pop up your hand and ask any questions or share any experiences. Please make sure that mics are just off during the presentation, otherwise it gets a little bit distracting. And I think that's about it. Karika.
Good morning, everyone. Good morning, Caleb. Thank you
Morning.
very much for the invitation. I'm just going to see if I can quickly share my screen with you guys, and then you can just let me know if you are able to see it.
Yes, we can.
Okay, awesome. Let me just see if we can start. So, good morning, and thank you very much for giving me the opportunity to chat to you guys about superbugs in the pre-hospital environment. Just a little bit about me. As you heard, my name is Karika. I am the infection control specialist at Mediclinic Santon. I hold a diploma in infection control through the University of Radboud in the Netherlands, but I'm also ICU trained. So while I understand that the hospital and EMS setting differ significantly, there are certain principles that remain universally applicable across the healthcare spectrum, which I hope to emphasize today. So let's jump right into it. So how I got to discussing superbugs with you today, we recently admitted a patient within just 2 days cultured a notable superbug. This prompted me to investigate the patient's background, including where he was intubated and who was involved in his care. In the hospital, we aim to establish a baseline for all of our patients. This helps us identify any interventions in the healthcare setting that caused harm or highlights areas where we need to enhance our processes in patient care. So I don't know if any of you know much about IPC work in a hospital, but I'm happy to branch out on that if you've got questions. So we basically look at anything and everything a patient cultures, and then we looked at what caused it. What caused the harm? Where does it come from? So we basically go down a little rabbit hole. So if we just speak on superbugs, what exactly qualifies as a superbug? You can basically envision them as germs donning like an iron suit of resistance. These organisms withstand even the most potent antibiotics as well as standard cleaning and disinfectant practices, allowing them to persist on surfaces for extended periods of time when left undisturbed. Research indicates that Klebsiella pneumonia, which CRE positive, can survive on surfaces for up to 30 months in optimal conditions. So a little bit more about microorganisms that is resistant to antibiotics. They mainly acquire this through natural selection, coupled with some genetic mechanisms to enable them to neutralize a drug's effect. The emergence of antibiotic resistance exemplifies evolution through natural selection. Within a large bacterial population, some individuals may naturally carry a trait arising from random mutations in their DNA or to acquire genes that grants them a slight resistance to antibiotics or even before exposure to the actual drug. The introduction of antibiotics creates a selective pressure, killing or inhibiting the growth of the majority of resistant susceptible bacteria. Then it's basically survival of the fittest. Only a few resistant bacteria endure the treatment. Then, with the susceptible bacteria eliminated, the resistant ones actually face less competition for resources and they quickly reproduce and transmit the resistant genes to their offspring. Over time, this population then shifts predominantly to an antibiotic resistant strain, I have found a lovely little video on YouTube, which I'm happy to share with Caleb if anybody is particularly interested to dive into the different mechanisms of antibiotic resistance. So I'll put that maybe in the chat a little bit later. So how do we prevent, or how does your ambulance or response vehicle basically turn into a fomite fairy? So picture a triangle literally directing you to disaster. So I see it as number one, lack of information. The concern is especially pertinent during interfacility transfers. Rather than your emergency response aspect duties, are you correctly assessing the risk profile for your IFTs? A considerable number of patients from long-term care facilities, nursing homes, and even those with prolonged ICU stays actually becomes colonized with superbugs. Let's dive into the right information that's essential for patient care. Is that sweet little granny just your 11 a.m. transfer back to House Sunset? Or could there be more serious underlying issues that have severe consequences for your next patient or even for yourself? It's crucial to understand that the patient's background, including their origins, and even sometimes in some cases travel history, can significantly increase their risk profile. Unfortunately, many long-term care facilities, certain hospitals, step-down facilities actually become breeding grounds for superbugs, which presents a serious threat despite their seemingly innocuous appearance. So then if we move over to the second thing, it's, I like to call it the glove gamble. This isn't just about wearing gloves, it's about how we remove them and basically what we do afterwards. In our profession, it's often a matter of black and white. If there's bleeding and body fluids, we are wearing gloves. However, the challenge with superbugs is that they are invisible. I assure you my job would be so much easier if they simply weren't invisible. Firstly, the removal of gloves are crucial. It's easy to overlook, but incorrect removal can really spread contaminants. Make sure that you actually peel them away from you so they don't touch the outside of your skin. Next, also consider the high touch surfaces. Think about all the places your gloved hands touched. Equipment, doorknobs, patient beds. These are all key points where germs can transfer. Always be mindful of where you are contacting. Finally, let's not forget about hand hygiene. After removing gloves, it's really important that you guys sanitize your hands properly, preferably if you've been in contact with blood or body fluids to wash with soap and water. This final step really ensure that you do not carry germs forward. Remember, small actions can make a big impact in preventing the spread of infections. Then if we look at equipment, managing your equipment, especially in environments where chaos is more common than calm. Firstly, even if sterile areas aren't your expertise, small changes can lead to significant improvements. Think about how you handle your dirty equipment versus your clean equipment. It's crucial to have a clear distinction and process in place. Finally, it's also important that you go back and scrutinize your cleaning and disinfectant protocols. How robust are they? Is it easy to overlook a critical step, but that there is major consequences? Remember, effective management of equipment not only ensures your safety, but also overall efficiency is also improved. I came across this little acronym when I did some research for another project that says DMS. So what does it make us think of? So it basically stands for doffing, have a mind map in place, and then sanitize. So if we have to connect these steps in our everyday practice, it basically just focuses our mind on removing the dirtiest items first, which then minimizes the risk of contamination. And think about your glove removal technique, which is crucial. And next, before you take off your masks, your eye protections, your stethoscopes, your other resource equipment that you've used, have a mental map in mind of basically where those items have been and where you are placing them. Because if you've used them and you've placed them somewhere, not just the equipment, but also the area where you've placed them has to actually be cleaned and cleaned well. These steps all prevent cross-contamination. And then finally, after you removed your PPE and you've packed away your equipment, the important thing is actually to clean your hands well. I think we've all seen it. I'm going to delve a bit deeper into this because I've, in my hospital, I am known for hand hygiene and checking on these things with our staff. But my question to you is, are you actually doing hand hygiene correctly and efficiently? So if you think about sanitizer, you need to think about the amount of product that you are actually taking. Are you taking enough product? Because simply just having a short spray, which you can rub between your fingers and your palms and it's dry in a couple of seconds, is not actually enough. And you need to take a palmful and then follow all the steps. There's about 8, depending on which protocols you follow, there is different steps to this, but basically cover your hands and be able to rub your hands vigorously for 20 to 30 seconds. Otherwise, it's good old soap and water. But if you are not doing that step effectively, you are basically thinking your hands are clean when they're actually not. And especially when it comes to superbugs, you really have to dive into that and make sure that is done. And then lastly, this is really very short, but we have to take a moment to reflect on a powerful idea. If we are the vector, we must also be the veto. So what does it mean? It means if we are the vector, implying that we can spread contaminants, we also hold the power to veto the spread by adopting meticulous practices. The key lies in our commitment to hygiene and safety protocols, and to remember vigilance makes all the difference. I encourage you to actually go out and have a critical look at how you and your teams assess the risk profiles of the patients that you service. How well is your hand hygiene, and how robust are your cleaning protocols? So with that, that's the end of the presentation. I thank you for the time. I'm open for questions. I do have some slides that I can share with you guys about bugs that became not so invisible through a little project we did last year. So I just want to hear from Caleb if there's somebody following me later.
Nope, it's just you. So I think we'd love to sort of have your experience from the sentence space.
I'm literally open for questions. Can I just quickly stop sharing my screen just for a second? I just want to open the, it's unfortunately on a different slide. Let me just close this down quickly. Now I'm going to open the slide. So like I said, my job would actually be very much easier if germs weren't invisible. Oh, guys, I'm going to try very hard not to close you, not to close down the chat. All right, I think I've opened it. So last year we did a little Halloween themed thing across a lot of hospitals. It's a couple of hospitals around Joburg North. We collaborated, and what we basically did is we went out. We all know our hospital's cleaning protocols, so we know exactly what time the cleaners come in their morning routine, and when their afternoon routine starts. So what we did is, in the mid-morning, between like right before the mid-afternoon cleaning teams would come in, we went around the hospital and we swabbed inanimate objects. So we went around and we swabbed IVACs, BP cuffs, ECG machines, Dynamaps, keyboards. And this is keyboards not just from people that work in clinical areas. These are also keyboards from reception and account staff. We did lift buttons, we did access control, and okay, I'm going to share my screen again. Just hold on for a second. And we basically put them all together. We put the names of what we swabbed on, but not the hospital from where they came. So this is completely anonymous. But this allowed us to basically have a look at what we cultured. So this will just basically I just want to stop sharing and just see which way this slides are going so I don't go the wrong way. We can basically go, or we can go either way. It doesn't really matter. All right, so you'll see, this is an agar plate for you who don't know. This comes from the lab. So when the lab draw bloods for blood cultures, they basically take this is a blood agar. There's different agar plates. They basically take an agar plate and they then, in a zigzag motion, I don't know, can you see my mouse or not?
Yes.
Right. So in a zigzag pattern, they basically spread whatever they have cultured on here, like this, and then they inoculate it for a couple of days to see what grows. So we didn't actually pay the lab to culture and tell us this is a Klebsiella or these are Imerus A or Acinetobacter. We just said we want to see what actually grows. So we didn't culture them, we just grew them in the lab. So this you can see came off an IVAC midday that was standing around a hospital. The second slide, you'll see that there's a black line right through the middle. So these are two BP cuffs. So you can see this is an actual BP cuff. I don't know if you guys all use what you call it, single-use items when it comes to that. This specific facility does not use single use. And there you can see, I don't know, I'm not a microbiologist. I don't know what is actually being cultured here. Then this is an ECG machine. There's two of them actually. Dynamap, I want to get to the keyboard. I don't know how, and then a part of this, half of this was a phone, and the other half was a keyboard. Okay, here we go. Lift button. Sorry, this one was quite a lot of condensation there. Access control. We all go to hospitals and places, and any building we go into these days has access control buttons, ringers, those type of things that we got there. Yeah. So this is just a few of the swabs that basically came back. I want to see if there's anything else that's here that we can remember that's interesting. I think that's all the ones I have left from the campaign we ran. But just to show you that superbugs are really a problem, and they spread very, very easily through contact with hands, equipment. And the scary thing is, like I said earlier in the presentation, these things can live in an optimal condition on a flat surface for longer than 30 months. That's 2.5 years. So if you missed cleaning that one thing that was in contact with a tiny old little granny that you just transferred to House Sunset, if she had a CRE and you didn't know, you packed it away in your bag and it's forgotten, you don't really use it, it actually becomes a vector for everything else that it touches in your bag. So it's just a bit of a mind shift. I lovingly refer to IPC, infection control, as a rabbit hole, because the deeper you actually go into infection control, the scarier it gets. But you also, I always tell the nursing staff, you kind of need to know where to stop, where to know it's there, but then also know what practices you've put in place. Because I see people sometimes go down this and it drives them absolutely batty because they get scared. They get scared to process, they get scared to work in hospitals once they've actually seen what's out there. So by showing you guys the slides or the agar plates, it's just basically bringing microorganisms to life, because it's a lot easier to be mindful of something that you know what it looks like than something invisible. So the next time you touch an escalator handle, a lift button, for that matter, a keyboard, like I look at my keyboard every other day and I'm like, I wonder what is on here, because we go into the hospital, we go into situations, we simply come back and we continue our work and we type. And you don't know what you touched on your way unless you've got a very rigid hand hygiene protocol in place for yourself. And like I always tell my nurses, you do not know who used your equipment. I think you guys are a bit different. You have your own jump bags. I don't know if you've got jump bags per ambulance or vehicle, or if you've got personal bags. But you do not know who managed your equipment prior to you coming on shift, like even the back of your ambulance, your response vehicles. You do not know if the guy or girl climbed into that vehicle with bloodied hands or gloves, and then you're touching the same steering wheel, having your morning coffee. So it's just a bit of a mind shift that also it's maybe important to do a quick wipe down in the mornings, just after shift change, because these things are really out there. We recently had a presentation where they showed us a map of Africa, and particularly South Africa. If you look at it, and tiny little blue dots basically represented a CRE infection. And in the Western Cape area, we had a couple of dots here and there. I remembered when I started in IPC, like CRE was like a thing that you would phone like head office for, inform that you had this in your hospital. And it was really like something in the Western Cape because they didn't see CRE infections there. And when we looked at this map, the further we go up north into the northern parts of South Africa and then north into Africa, the darker this map gets. And I can tell you now, on any given day, hospitals in the, let's say, from Central Region upwards, will have patients with CREs present in their hospitals, in their healthcare setting, people that you guys also service. I know in some of the mining communities, if we look out further towards the West Rand, I've got colleagues who work out there, that the resistant superbugs have basically taken over not the hospitals, but the actual communities where the people live in. These people come already colonized with superbugs. They are not ill, they're not actively ill, they are coming in for elective procedures. But when their swabs and things come back, they are already colonized with superbugs. That's why I highlighted the little old granny. You know, she might look sweet, she's all healthy. She came for a hip, she fell, she broke a hip, she came, we fixed it, we sent her on a merry way. But she might be a carrier of superbugs, and it's not something that we are able to see. But it's something that we just must be mindful of. So I think I've rambled on enough about superbugs and hand hygiene. If anybody has got a question or want to ask something, please feel free to unmute. I am going to mute and I'll wait. Hi, Cindy, please unmute and ask.
Morning. Thank you. Thank you for the presentation today. So one of your comments was at shift change, it's a good idea to wipe down your vehicle. Now, the different bugs are resistant to different cleaning materials. Some will only be killed with soap and water. So what should we be using?
So that is a very controversial question. So what I mentioned is you need to go and look. I'm sorry, Cindy, I don't know who you work for. You need to go and look at your cleaning processes. You need to go and look at your protocols and look at what they are using. And then I can unfortunately not promote any one product or company. I think you need to take it up with I don't know. Sorry, I don't know how your structure works, but this, in my case, would be a discussion I would have with corporate, and then we would look at, you know, what is the resistant patterns, or what are you predominantly seeing? Okay, what you need to clean. But I do believe that most ambulance companies do look into these type of things thoroughly, and then choose the best product based on what your situation is. So a good frame of reference is also you cannot disinfect something that is not clean, right? So you cannot go and take something dirty. If you think about, let's take something like a dishwasher. If a dishwasher has got certain stages, like, right, it's got a rinsing, washing, and then it goes through a sanitizing phase. So if you basically clean something and you take the knife out of or the plate out of the dishwasher, and there's still debris, like little food particles stuck to it, it basically means even if it went through the steam cycle, where that food is stuck, it means it's still dirty. The same thing applies basically. Let's use something as a laryngoscope blade. If you simply wipe it and do not take off all the organic material, even if you then go put it into a Sidex or we will probably use like a Sidex or an autoclave. If all the organic material isn't removed, it cannot be disinfected. So that's why I said in my presentation, it's really important that you go back and look at what your company uses, what is the products, what's the active ingredient in your product, and then it's important to scrutinize if that active ingredient will actually stand up to most of our superbugs in the healthcare setting. I don't know if I answered you 100%, but it's also important that there's a wash cycle in your cleaning of your vehicles and your equipment, and then there's a disinfectant. So basically, cleaning is always a two-step process. It's always you wash with soap and water first, and then you go over it with a disinfectant because you cannot disinfect dirt. So you need to look at any cleaning has to have basically two steps. So I'm hoping I answered you, Cindy.
You did things. It's perfect. Yeah, it
All
was
right.
about something to
Yeah.
say. Wash.
Yeah,
first,
so
then
just go
disinfect.
back, look at what you're using, look at what the active ingredient is. And one of the other things I also probably forgot to mention is also look at, I know a lot of us love to use wipes, right? Because wipes are just so freaking convenient. And you can simply take it and wipe, it's readily available. But you need to bear in mind that wipes in some places have actually been linked to outbreaks because people tend to leave them open. And the first wipe is not always, the first wipe's perfect. It's moist, it's new, you can go. But that's it where it becomes dicey is that middle and those last wipes. You've all had baby wipes in your car that you use for various things. That last wipe is basically as dry as the packet on the outside. As soon as your wipe starts drying out and not having enough moisture, you can also know that your cleaning agent has also dried out, so that will also make it less effective. So just also be mindful of that. And then the other thing is also please look at expiry dates, because in some places we have to mix disinfectants and cleaning solutions daily. For that active ingredient only stays basically alive and active for a certain period of time. So it's not like, you might have that spray bottle standing there, but the question is, when was it mixed and what is the expiry date? That's also just very important to note. So. Any other questions?
Okay, can I maybe ask what should, and this is probably a loaded question, but what should a system look like for monitoring whether we're cleaning well or not? Sort of how often are you guys swabbing services and sort of checking systems? I know you guys sometimes also use the fluorescent
Yes.
light stuff, but like what does a system look like in your spaces, and then maybe what could it look like for an ambulance space?
Okay, so what we normally do is my long-standing mentor has always said if you swab something, you're going to find something, right? So you need to be I always feel you have to be very careful with swabbing. Like this little, the swabs I showed you guys were really just like a Halloween themed. I think the thing was called Nightmare on Clean Street, right? It was literally just a little awareness campaign that we ran. We do not regularly go around and swab surfaces because, like I said, if you swab something, you are going to get something. But it's almost like that saying where they say garbage in, garbage out. Like you can go swab everything and you will get something. But the question is, what does it mean? As you guys also saw on those swabs, there were various different things. It's not to say it's one thing. It won't give you an answer to basically swab things around your ambulance, around your base, around the hospital. It also doesn't even make sense to swap people. I last week actually read an article where there was an outbreak in a hospital and they tended, after a long thing where they checked, they decided, okay, they are going to swap the healthcare workers, which included the nurses, the doctors, the physiotherapists, the cleaners, and everybody to see, if somebody might not be colonized, with the superbug and they are the ones spreading it. They went and they swabbed and then they got the results back, and there was only one person out of the 30 people that they swabbed that basically tested positive for the superbug. But also interesting enough to see that the resistance pattern that this person had with the superbug that she was carrying, it was the same superbug, but the resistance pattern to the one in the hospital also differ. So we showed that the resistance pattern, or the superbug she was carrying, had a different resistance and like a different antibiogram, which actually means that hers came from the community and not from the hospital. So in a hospital setting, like I said, I would not promote swabbing. I always say you can only go to person swabbing, vehicle swabbing, equipment swabbing, unit swabbing, drain swabbing. Once you have established that you have got 100% hand hygiene compliance and you have got 100% environmental cleaning compliance, and not just you, the one person working there, has got 100%. I mean the entirety of your staff that work in that unit or on that vehicle has 100% for both. So I would put swabbing out of your minds. So how would you check effectiveness of cleaning? So it will be, first of all, have a proper routine. So that helps. Like set times, I know it's probably more difficult, and probably in the hospitals also, that sometimes why these things fall through the cracks, because at the specific time when they're supposed to be cleaning, an emergency happens and they get pulled away. So I see it as basically having a little checklist for the day that, certain things happen. So you can't go off shift unless certain things happens. And one of those things should be thorough cleaning of equipment. Like prior to you guys starting your day, you must be sure that your equipment and things are really clean. And I'm not talking now the underside of the vehicle or the underneath the couch or the whatever. I'm talking about if you think about high touch surfaces. If you can verify that high touch surfaces, places where your hands go, those things have been wiped and are clean, will really go a long way. Then also personal hand hygiene. And then I do find that, spot checks we do spot checks with UV checking basically daily. I've got people throughout the hospital in each unit that has to do about 5 checks for me a week. Personally, I also go do a couple a week, and it's random. It can be after a case, like let's say you've had a into hospital transfer, they told you, listen, this patient has got a CRE, the patient's isolation, they are going to a step down, geared for isolation. So when you come back, the person, head of the shift, will then take a little UV marker, go through the bus, go through the stuff that you guys know is high touch, right? And then basically go make little marks. And you guys as a team then basically can go and clean. When you're done, you can then basically make sure that everybody has reached all of the UV little marks. In a hospital room, it works quite well. A supervisor, myself, or one of the link nurses will go in. We basically tick off a little, a few things. I try really keep it to high touch. My cleaning supervisor, she's a little bit more Rambo. She actually, I think, marked the inside of a paper towel dispenser the one time. And I was like, Joyce, no one's hands are going there. But she said no. She wants to make sure that the cleaners are thoroughly cleaning. So, but it's a useful tool. It's useful to see if these things actually have been cleaned. They actually rub off the UV cream, the UV pens actually do rub off very quick, very easily. So any kind of like friction will remove it. So that's the best way I have found. I know there's companies and people who do APT testing. I'm not that versed with it, so I'm not going to touch on it for today. But there is various ways, but good old manual checking is the best way you can verify that your things have actually been cleaned. So yeah.
That's really interesting, just from the point of view that it feels like testing and maybe swabbing would be helpful, but I think the point you've made is so useful. Is like if you swab, you're gonna find stuff, but maybe figuring out if we're cleaning stuff appropriately is better.
Yes, because literally you cannot, like, if your protocols are in place, like the last guy that used the ventilator, did they really, open it up, clean it out? When last has it gone for filter cleaning, those type of things. And I promise you, when an outbreak comes, and I've dealt with a few in my career in the hospital, you really have to go. And what I've seen with both or the three, like I was involved in, is literally going back to basics. Information about the patient, restricting their movements in the sense of, we're not moving you from bed 8 to bed 2 to bed 3, just to make space as, we need it, restricting movements, and then just basically going back to access control, limiting the amount of people that come in and out of those areas or work with those patients, especially if you know. And then also good old equipment cleaning, like thorough cleaning. Awareness goes a long way. So that's why the presentation earlier also focused on, I know you guys work in a vastly different, area than myself, but like emergencies, is emergencies. Even in a hospital, I don't go stand there with a clipboard and check, IPC principles in the middle of an emergency. It just doesn't happen. What I do sometimes do is go and stand as an observer. Go and stand and see in the middle of all that chaos when they bring in the patient, where, and I actually did that the other day, like when that trauma comes in, where does the dirty equipment go? Where does people's hands go? Because everybody's gloved up. You feel safe because you can touch whatever because, we're all a little bit invincible when we've got PPE on, right? But then when everything starts to calm down and the patient is kind of like handed over, everything is stabilized a little, you see people visibly relax. And you then, if you just stand back and you see where did the bloodied head collar go, the board, and the IVACs, the syringe drives, and then where does people's hands go? So that makes a difference because if that patient has a infectious disease or a superbug, that means you have to be vigilant when the calm has been restored. You need to know where to go and what to clean. That's why I also said it's very important, like that mental mind map for you guys as well. Like you've got gloves on, right? But the next second you might have to transport this patient now. Do you take your gloves off or do they stay on? And also, where did your stethoscope go? Where does your eye protection go when you're done? Or does it just get simply placed back in the bag and you don't think about it until your next call? So it's just a little bit of a mind shift and just thinking about infection control, because sometimes it might not be a superbug that in the end could, maybe run its course and go in. Sometimes you can get exposed to something you can't take back. And it was also highlighted to us, quite recently when there was an outbreak of viral hemorrhagic fever, Ebola, basically in the DRC. All of the Joburg hospitals are very open to that because we have a lot of travelers. And I've firsthand seen how travelers can manipulate the system to get past the thermal cameras and all of those type of things in airports. And, if you don't read your risk profile correctly, you might end up with something that you can't take back.
I mean, I know on the last Santon neonate presentation, there was that talk about the family who arrived with a possible viral or some kind of uncontrollable infection that ended up being bilharzia, but they managed to get the whole family through
without divulging too much.
Yeah.
We got a phone call to say that one of the doctors accepted a family of patients that is presenting with a fever and a red rash and facial and neck swelling.
Yeah.
Significant facial and neck swelling. And they are coming from, I think, Malawi, it was, right? And all the alarm bells go off in your head because what are they coming with? The last patients who did that to us, and this is now, I think, a bit more than a year ago, ended up all having measles. And for those of you who don't know, measles has got like an R rate of between 9 and 12.
Yeah.
So R rate means reproductive rate. It is for each one positive person, they can effectively infect 9 to 12 people around them. And it's also airborne spread. And these patients tend to come on a commercial flight. So imagine being trapped on a commercial flight with somebody having measles. Most of us think about it and we should be fine because we have been vaccinated, or you think you're, but also what we've realized, and it's also one of the talks we had the other day, is that your immunity to certain things, childhood things that you got immunized for as a kid, is slowly starting to wean. And that's why a lot of microbiologists and virologists are asking us to actually, maybe update and get booster shots for some of these things, because we've seen. I think 2 or 3 years ago, my first measles case that I've had since I did IPC, we've recently had quite a few, but I think I did IPC for about 6 years before I saw my first measles case. And it was an adult, a 20-something-year-old adult from a university. So then you already know, like, it's not just a kiddie disease anymore. And sadly, that person was actually vaccinated as a child, which just indicates again that you might need booster shots. But yeah, that's the infection control rabbit hole sometimes we go down. And when we receive those patients, we luckily knew. The funniest thing is the people that transported the patient here came in dressed to the nines, but they didn't put a mask on the patient.
Wow.
So we let our vector basically walk free while we are all protected. And one of the simple instructions I asked is, just put a normal mask, not an N95, just a normal mask on the patient. So if it's anything viral, like a droplet spread, we kind of contain it until the patient gets into isolation. And then there, obviously, people will wear their PPE. And it ended up just luckily being bilharzia, but it could have been anything else. Like, I
Yeah.
feel some days like infection control is like a dice. You roll it, you throw it, and like you see what comes up. Like, what instigated this case of you and me chatting was also like, you get a trauma patient, initially you don't expect anything from a trauma patient, because I mean they were
Yeah,
healthy,
they should
they
be
are not
clean.
ill.
Yeah.
Yes, they should be clean.
Yeah.
Like their focus should be coming from, their wounds. And then when I got the cultures back, I was like, wait, what? I
Hold
was like,
on.
did we? And my first question was like, did we tube this patient? I was like, because if we tube this patient, I'm in a sea of trouble.
Yeah.
And I had to make contact, with everybody who treated the patient and figure out where this patient was tubed, because this is not an organism that you should be seeing in a 20-year-old, like before you got here, healthy patient, and why it was important for me to follow up is if one of you guys have tubed that patient, right? It might, let's say, what, maybe he lives with his elderly granny of 90 who's colonized, né? So he became colonized. But the risk to you guys are now, you are, for instance, the one who tubed him, right? Your laryngoscope went down his throat, you tubed him, you successfully handed him over. But if you are then not making sure that that blade is treated properly and cleaned well, just by putting it back in your bag already caused a risk now, for the entire bag, yourself, and the next patient you are treating. And that's just a little, tick of infection control, how our brains and minds think about these type of things. So I
Yeah.
hope I didn't bore you much.
I do see there's some
I'd like
questions.
to say something. Oh,
Go for it.
sorry. So further to that, but how our minds think. One of my personal bugbears is people who touch elevator buttons and doorbells with their elbow. I kind of started during COVID. They do that, but the elbow isn't the thing they always clean. So
So I'll
it's gonna
say,
ruin
like,
everything.
I must say, there was this thing with elbows and everything. And even when flu season comes around, in IPC, people always tell like, sneeze into your elbow. And I'm like, oh, please don't do that. Because nobody washes their elbow. Nobody goes and washes their, like, I always say if you can, like wash and like sneeze into a tissue, throw it away, and then go wash your hands. Or even like if you have to sneeze on the inside of your shirt, because nobody's going to touch like the inside, the front of your shirt. And if they do, they deserve to die. So that's just normally what I joke with the nurses. I'm like, try and like sneeze and wash like in your hands, because if you have sanitizer available, it's easy to clean your hands. If you've got soap and water, even better. But I get you, Cindy. I also have got a pet peeve with people like touching elevator things with their look, probably their elbow, like is also not touching them, because if you think about your fingers and stuff, they tend to go to your nose, eyes, mouth very easily. So you can't exactly get your elbow in your mouth and in your eyes. I bet there's somebody who just tried. But anyway, so that is probably, safer if you really don't have access to sanitizer. But I've learned that, you always keep a little bottle of that just for in case. But yeah, there's a lot of little things that you pick up when you actually look with infection control eyes. Is
See,
there
there's
any other
a
questions?
few
Please go. Just
questions.
unmute and ask.
So I just wanted to,
Can't
so
see
the one is,
any.
what is the potential for viruses to penetrate gloves? And is there a benefit to double gloving? I also understand that nitrile gloves might be better.
Oh, you guys are coming with the heated ones. Right. There is some cases where I do think that double gloving, in some cases, The only case that I know where I will definitely double glove is in a case of viral hemorrhagic fever, right? And then it's not, I don't think it's in the sense of that we are scared that it might go through the glove, right? I think it's more in the sense of removing the contaminant layer and still keeping a layer of protection for yourself, if you think about that. You know, when we spoke about glove removal, how like the worst contamination is on the outside. So I always say in the hospital, I would love to get access to a tin of paint, right? I do think the cleaning supervisor might kill me if I do this, but if you put on a pair of gloves, right, and you dip your hands into a tin of wet paint and they actually come up, right? If you challenge yourself to remove your gloves without getting any of that paint on you, right? Um, you did a good job. But I don't think anybody actually can get it right. And one of the nurses were like, I'm sure I can do it. I'm like, okay, bet. Okay, you can do it. I believe you 100%. You'll be able to do it. But now you need to tell me how long did it take you, right? And do you remove your gloves like that every time you wear gloves? That's the question. And then he looked at me, he's like, no, I don't. So I think that's the benefit where it comes into having a second pair of gloves with like really infectious diseases, um, like to basically double glove. So it just gives you an added layer of protection so that you can remove the gross contamination and still have a layer of protection. I am not an expert on glove types and whether nitrile is better. I do think if you've got a question like that, it will be very valuable if you go and look at the product you're using. I think go look at the safety ratings. Just go read a bit, go read about the products you are using. And if you are working for one of the more corporate companies, um, depends, most of the stuff should have gone through some sort of testing. I'm not always sure with the smaller companies, you know. I also sometimes see, and I hope there's no reps on online, but a lot of them push a product, you know, for the sales and not necessarily for the safety. So just if you are using, and this goes for everything, not just gloves, this goes for cleaning equipment, it goes for cleaning. Um, my English airtime is now finished for for basically your, I said contaminants, for your liquids, what you use to actually clean with. You know, it goes for everything that we use. Just go make sure, go read up a bit about it. Just go look at these stats, go look in most good products and most good cleaning things do have studies and trials and cases attached to them where they can actually prove their efficacy. So look for that.
I saw there were one or two other questions, so I'm just gonna
Yes.
jump through that.
go.
Who carries the cost for treatment if a patient is admitted to the hospital and acquires any of these infections in the hospital or from the emergency care worker?
Right. So in the US setting, it's most definitely to the hospitals, but also the South African medical aids have woken up with a vengeance. So what we've been doing for years is we report if a patient gets an infection in the hospital. We basically report it as a healthcare associated because it's not a hospital associated, it's healthcare. Because the patient could have picked it up anywhere in the healthcare setting. I lovingly refer to my hospital as Corner Peter Place in Maine. So anybody who works on this corner, you are all healthcare workers and you are all in it. So if a patient has acquired something in hospital, we flag it, and we also tag it as that for the medical aids. And they have sometimes come back to say, listen, you know, we are not funding that. And then most likely the cost falls back onto the patient. But in saying that, if a patient can prove that there was gross negligence, right, then basically they will go to court and then sue the hospital. And then there has been cases, not at my hospital, but I was part of a case a couple of years ago where a hospital in another province actually were able to prove, you know, gross negligence. And there's always settlements and those type of things that goes on. But what I want you to understand about healthcare associated infections or picking up a hoho in a hospital setting is sometimes it really is inevitable. It is really it's an easier thing for me to explain to you like this because I think it makes more sense to people than hohos. If you have a severely sick patient in ICU that's on all the inotropes, on constant ventilation, and he is so sick that you can't turn him, right? and you eventually, when he gets better, and you turn him and there's now a pressure sore. You understand where it's coming from because the patient was too ill to basically move. And sometimes the same thing happens in a hospital. Like, I'm not saying a patient catching something completely off guard, but sometimes the patient comes in and they get infected with their own gut bacteria. Like, they go for an operation or they've got a break, and or they've got like it's a gunshot shooting. The patient was shot at the abdomen. You know, we all know your abdomen is full of fecal matter and all the organism that goes with it. And sometimes those organisms basically get displaced by the patient's own aspiration and that type of thing. So a lot of stuff happens and it's not really within our control, but that's what is within our control. We definitely do try to mitigate as much as we can. But yeah, no, hospitals and people are getting held liable for hospital-acquired or healthcare-acquired infections.
But I think also just at the end, the patient really does carry the cost because they carry it
Yes.
personally as well.
Unfortunately, I've known one or two patients, you know, because we have doctors here that really specialize in infectious cases, right? They see cases from all over South Africa where they get referred to this doctor as like a last hope. It means that they got like an infection somewhere in their wound and in their recovering process, and literally they cannot get rid of it. They have tried everything, so they come to us, like to this doctor, to see him. And I already know if he admits somebody they are severely septic, the wards know his patients go straight into isolation. And I've seen where he's seen a patient, he's taken his patient back to theatre multiple times, debrided, to try and get, you know, a handle on this infection. And this poor patient inevitably died, just because he his body just had nothing left. And it's not an infection that he got here. It's an infection that he picked up when he went home and it got into the joint and they just could never get rid of it. He saw every specialist in the last 10 years and in the end he ended up dying of a complete superbug. I must tell you, it sounds terrible, but the day that body left my hospital, I sighed a sigh of relief because that man was completely pan resistant to absolutely everything.
Oh,
There's no antibiotic on earth that could actually kill what he had. So it was a relief to know that, you know, that possibility is no longer in our hospital to spread. But it never did. So
I think just the last question. There's quite a lot of questions about UV lights versus chemical versus soap and water. What are your thoughts?
all different things. You cannot have one without the other. You
Okay,
need to
that's a really
elaborate
cool
on the
answer.
question. I want to
So
see if I
the
can
question
open the
really
chat.
is there any data to suggest that one is better than the other and like
There's absolutely, it's like comparing apples and oranges,
yeah,
Caleb.
really
So
good question.
like cleaning has got a place, right? You cannot skip cleaning. You cannot skip disinfection, right? The optional thing for me is maybe UV light, né? Like, if you know your processes, but it's also a nice way to check, right? For us who's sitting in supervisory roles, it has to check and make sure things are you know, done. And you know, it's every now and again, if you go through a bag or through an ambulance, you quickly mark it and you want to see did that shift actually go through and do what they were supposed to do. It's
I think
reassurance.
I think
Remember,
the question
there's a
here
difference.
is more UV lights for cleaning. So the sort of zappers and stuff like
The
that.
zappers. Oh, that's what we're
Yes,
referring to.
I think so. Yeah.
Look, I think, okay, to be very honest with you, I do think those zappers has got, it's probably the same as fogging. It's got a place, right? But it's also got severe limitations. Okay, so on the zappers, and I've explained this just last week to somebody, and same with fogging, kind of. Like, fogging is that little chemical steam that they pump into an area once they've cleaned it. Unfortunately, fogging is not effective if you've missed a spot. So if you, I'm just going to call it like it is. If you missed a spot by not cleaning it somewhere, fogging is not going to make that spot clean. And then basically by having that spot not cleaned, it means it's left there and somebody can then come from there, transmit it all over the specific room again. Okay. And it works the same thing for me with the zapper, right? They put it in a room. Okay. It zaps its little rays. But if you think about a room is not 100% empty. There are equipment, there's chairs, there's beds,
Yeah.
there's there's nooks, there's crannies. If those rays cannot bend, it's like light. Think about it.
Yeah.
Light doesn't bend around corners to reach. So wherever those rays don't reach, basically has not been cleaned. So fogging for me and zapping, that UV light zapping, will never ever take the place of proper two-step cleaning and disinfection, ever. If you can rather spend your money on proper proper cleaning materials and good disinfectants before you spend your money on zappers or foggers. Hi, Jerry.
Hi. Yes. Earlier on, I heard you emphasizing on expiration dates for
Yes.
disinfectants and so on. So
Yes.
I'm someone that sort of like derives some comfort in understanding that medications don't simply lose efficacy at the point of expiration. So I just
Jerry, I'm
wanted to
sorry,
know.
I can't hear you very clearly. Your line has got a bit of
Also,
static on.
let me see. Can you hear me now? I think I must just use let me switch off my headset.
Jerry, I think it might be better if you type your question just into the chat. It's very difficult to hear you.
Okay, no problem.
Sorry,
Oh, that's
Jerry.
better. That's better.
Oh, can you hear me
Better?
now?
Yes.
Yes, let me just also make
Yes,
this a
yes,
bit
sure.
louder on my side.
Okay, no, it was my headset. Yes, I was just saying that earlier on during the presentation, I heard you emphasizing on expiration date of disinfectants.
Yes.
And I'm someone that derives some comfort in understanding that medications don't simply lose efficacy at the expiration date, provided, of course, you've kept them under ideal conditions and so forth. So I just wanted to know, is the same true for cleaning chemicals, or do they play by a different set of rules? Just want to get some understanding on that. I hope my
Very
question is clear.
again, like I'm also a firm believer that bugs and medication and those type of things can't read. Nee? So your jig that you've got in your bottle in your kitchen cupboard cannot tonight when it says, oh, it's the 4th of December, I'm done, just switch off and be done and be finished with it. But there's definite evidence to show that your efficacy don't laugh, but your efficacy goes down after you go past your expiry date, right? Then the company nor the person can verify that that actually, is the same as the product that you can actually rely on and what they proved in their studies. So I'm there with you, Jerry. I firmly believe that germs and things can't read dates. They can't say, ha, it's the 4th. I no longer work, same with medications and antibiotics, but it's there for a reason. And I wouldn't take the gamble if you have to clean something that is pertinent to patient care or for yourself, by using an expired product, because you might just get the one that really is kaput on the 4th, and it did read the memo to say it's expired. So yeah, I hope it answers your question. But and also in saying that as well, disinfectants and cleaning solutions can actually also become infected. I don't know if you guys knew that. So if you mismanage your cleaning, even something as simple as Sonar gel, we've actually had outbreaks in other hospitals linked to Sonar gel that was used, infected Sonar gel. So when they go and they squeeze it out on the patient, squeegee bottle, some of it always inevitably sucks back up. And hands, that always is, So sometimes that does happen. So always just check your solutions. Hi, Jimmy. You had a hand up. Jerry, did I answer your question?
Oh, yes, I'm covered. Thank you so much.
Jimmy, did you have a question? Just a mistake. Okay.
Then just some feedback for you. There's a few people just saying really good presentation. You definitely did not bore us. It's been a really big wake-up call. So thank you so much for sharing.
Thank you very, very much. The word of the day is bugs. I like it. All right. Somebody said picked up 2 superbugs in ICU last year. David.
Yeah.
Yes, I can believe it. It is really, that's a really hard environment to be in. And obviously I don't think you want to share your personal information, but it can happen. And sometimes if it's of no fault of your own and also no fault of the hospital, it just really sometimes happen. we're just glad you're still here and you managed to be able to get that treated, because some people that pick it up might not be that lucky. But all the best. Caleb, thank you again for the invitation. I really enjoyed chatting to you guys about my little pet, the pets I keep in the hospital. I always love to refer to them as my pets. Hopefully I keep them all wrangled and on a leash. So I'm happy. If anybody else wants to pop a question or has something else you want me to chat to me about, you're welcome. I think Caleb's got my email address, or you can just pop him a message. He can forward it to me. Yes, and thank you. I really enjoyed chatting to you bunch. And I hope you have a safe and lovely day.
Thank you so much. Thank you, everyone. The word of the day is bugs.